Well, thank you. Thank you for the perfect place in the lineup. Not only do we get the inspiration of, if you've ever had a season of life where you stack your habits, Coach Bronson just gave you the cliff notes on how to do that. Great job. And there's nothing like a very advanced cholesterol talk to come before mine. So I worry about losing my audience. It's something we work hard at our team to say, how would I talk to my parents about this? But at the same time, do exactly what Dave Feldman just did, which is, well, don't leave out the science. Get to the point that is what should be talked about, but is difficult to explain. So you're going to make me look great, Dave. My lecture has, actually, I'm going to push a button here because I have to hang tight. I got to set this other thing on displays when I do it here. System settings, hang tight. I do have this skill set down. And it is on mirror somewhere, arrange. Don't mirror. It's got to stop the mirroring. Hang on, it's in front of me. Mirror, stop mirroring. That's the button we need. Okay. Now I got it. Okay, we can do this. Yeah. And I thought hog chars were hard. No. Yeah, so we start with some disclosures. I do make money at teaching people how to do keto. It is not in the traditional sense that I have become accustomed to, which is seeing one of you one-on-one at a time. Writing books is a great way to do that. But so are the online courses, where the classroom is the new exam room for me, in a place where can I help you help your physician? Can I help you understand the conversation that should happen in the setting of your primary care physician and that relationship? So between being an author and taking the history of when patients come in and say, Doc, will I become that statistic? When you look at what Dave said, the most common cause of death in this room is heart disease. It is not a little part of the conversation on a ketogenic diet. It is something we need to have a very thoughtful and academic conversation about. That when I try to teach about this, I start with some very relatable moments. So, take a deep breath in through your nose and at least hold it for 5 seconds. And blow it out through your mouth. I need one more. And out. Those red blood cells floating through your system have a job to deliver oxygen throughout your body. And when you look at that primary role inside your red blood cells, they have some enemies that get in the way. That when we try to predict when those red blood cells are going to clot in a very important artery that supplies the blood and oxygen to your muscle of the heart, called the coronary artery, predicting that has become, well, almost a joke in the traditional path of medicine. How can we do it? And we have screwed it up plenty. That what we're really looking at is, well, we're trying to find this zit. The zit that you had as a teenager, and if it's prom night, you have studied your zits long enough to know, I can't squeeze that one. It's not going to pop. It's just going to make a bloody red spot on my face. It's very inflamed. It's going to hurt. So it's better just to leave the zit alone. And then there's the other zits where you say, oh, it's ripe. I can pop that baby. And that stuff that comes out, that caseating material, kind of like toothpaste, well, that is what heart attacks are made from. Heart attacks are the zits that happen in your coronary artery walls that pop. And when that toothpaste touches those red blood cells, it clots the blood, and that's a heart attack. So we're going to study some zits today. So we're going to say, how is it that we could prevent a heart attack? And if you walk into that physician and say, Doc, I don't want to be that statistic. I love this ketogenic diet, but I do not want to be that statistic. The first thing your physician should tell you, the most preventable risk factor for that heart attack is don't smoke, period. Do not smoke. Smoking cigarettes, number one. 100 pounds. You can lose 100 pounds if you're a 1-pack-a-day smoker, and you have the same risk of a heart attack. Number two, that he should, or she should, look at your blood pressure. Blood pressure should be controlled. Blood pressure is a very predictable measurement of a heart attack. And it's not without a casual mention of this that I still think a ketogenic diet is an awesome way to get your blood pressure back to normal, but it still should be something you monitor and control. But the next thing is a history lesson from 1955. It is where we screw it up in medicine because they had this great thing called the cholesterol panel coming out of UC Berkeley, very intelligent and advanced academians who we said, okay, what's a lipid panel, a cholesterol panel, and your doctor today is still going to order that. And he'll look at that and say, well, it shows me total cholesterol. He'll also mention things like HDL cholesterol, LDL cholesterol. And when you see these slides coming up, whenever you see that yellow oval with a little tail, that's the image I'm using to show you where does this come from, what exactly are we measuring, and then we're going to advance some things. We're going to talk about what is a C-reactive protein and where does that fit into this story, because that actually is number 3 if you ask me. Before we're looking at cholesterol, what is that C-reactive protein? And we'll talk more about that. But we're going to go back to those red blood cells, the ones you just oxygenated a minute ago. And that little rhomboid structure that's red, in my slides, that means glucose. And if you missed last year's awesome talk, I'm going to give you quick cliff notes on what those red blood cells are doing to either promote a heart attack or reverse it. So those red blood cells, they have structures, strings of globin inside them. That those strings have cups that have a magnetic pull for iron. We're going to drop some iron into those cups, call it hemoglobin, and oxygen has a magnetic pull to those hemoglobin units in your red blood cells. And it's the job of those red blood cells to circulate around all parts of your body from head to toe to heart and deliver that oxygen. But your oxygen has an enemy. And the enemy is glucose. When glucose gets too high, it will splat into the parking spot that's supposed to be for oxygen. And it's kind of like gum on your shoe. It is there for good. There is nobody with a crowbar that's going to remove that from your red blood cells. It's there. And it's proportional to what's your average blood sugar doing in your body right now. And that average blood sugar predicts how many of these seats have been splat. This hemoglobin will last, well, red blood cell and the hemoglobin in it will last 100 days on average. And as soon as the gum is sitting in that seat, it's there for the lifetime, the 3 months of that roller coaster ride to deliver oxygen. That if the oxygen comes along, it bounces out, the one that should have gone there, and now you're only giving 3 out of the 4 oxygen molecules a ride to your coronary artery, to your fingernails, to your toes. And when you do this, and you look at the average red blood cell, this is a red blood cell, and I took math and made it easy, so here are 25 hemoglobin structures. 4 oxygen molecules should fit on each of those, so we've got 100 oxygen molecules. If 5 seats are taken up by glucose, splat, and the oxygen can't bind, take a guess, anybody from last year, what the average blood sugar is for that? About 100. Yeah, your average blood sugar of 100 is a hemoglobin A1C of 5. It's my goal to keep my hemoglobin A1C below 5. I like to use my brain all the way up to the day I die, and I also don't want one of these heart attacks either. If we splat 1 more seat and take away the glucose from 6 spots out of 100, now we have an average blood sugar of 126. And there's your diabetes. Now you have increased chances of heart attack by 10-fold from the 5. As that blood sugar rises, the equation changes. And when you first look at changing average blood sugar, it is the step 1 that we work at in my practice before I let you look at your cholesterol. But when we get to our cholesterol, well, I live in the real world. We still look at lipid panels where the total cholesterol is measured, that triglycerides are measured, that there's a little APO A thing in there that correlates to your HDL or your good cholesterols. And then we have the bullet. We have the LDL, the bad cholesterol, that somehow is connected to heart attacks. But it's not a linear relationship. There's something more involved in this. So let's just remind you that in 1955, how did we do this? We had really great and well-intended people who took the parts of the zit and they separated them. We sent you to the lab, we put a needle in your arm, and we drew that blood, put it in a test tube, sent it to a centrifuge, and now we started measuring these spheres, these balls of zits. The outside is blue, it's water soluble, but the inside is filled with the stuff that's in zits. It's got fat, it's got triglycerides, it's got cholesterol. And this is very valuable fuel for every cell in your body, but it has a tipping point of when is that too much? I use this picture because I couldn't draw this. It's a 3D structure. They are not 2D. It is like a sphere, a ball. And those little yellow dots are the cholesterol, and the triglycerides are in there as well. That green structure around the outside is a marker because the cells need to know what you got in your zit. And that is a marker of APO B, APO A. It's got some numbers behind it. Those are details. We're not going to get that far into the numbers just yet. We're going to look at what happens with a lipid panel. It takes a smattery of these traveling zits in your blood, and it pulls out, it pulverizes, and it brings all of the total cholesterol into one section. It brings the triglycerides into one section, and then the markers on the outside you can measure those too if you want to. And when you look at cholesterol in the 21st century, 2023, we should be looking at it at this level. This helps us look at how big are the zits inside your blood? How big are those particles inside your blood? And are they hanging out long enough to become the bullets that do predict heart attacks? Let's see if I can unpack this in a way that doesn't lose my audience. The first thing I'd like you to notice about this slide is the number 500. It is a 500 nanometer, a measuring stick of 500. It's a really big zit. Okay? It also doesn't have the alphabet soup yet. It's called a chylomicron. Okay? Chylomicrons, well, they are large. They're very buoyant. They've got lots of fat in them. And if you did eat a stick of butter, and then you drew your blood, and you would see this little thin yellow at the top of it, well, that's fat. That's a chylomicron. But chylomicrons in healthy people should only last between 10 and 60 minutes before they're gone. If you have a good metabolism, if your metabolism is doing what it's supposed to, I should not see any of these when I check your blood fasting at 12 hours. So these are off the table because I'm going to assume they're gone. But what happens during that time is those triglycerides, the ones I just dumped at the bottom of the slide, they're going into your cells. It's a very valuable resource within your body. The triglyceride, those fats, are important for getting the fuel needed for your cells. And the way you get them to your cells is through these particles. It is not necessary that the cholesterol gets there in your cells. Your cells have DNA that can make cholesterol. It is super important for every cell. But most of your cholesterol is not in your blood. It's in your cells. When I draw your blood, I'm skipping the biggest deposits of them. They're intracellular. Your cell makes it if it's really irritated and not getting its delivery for the day. But when it's dumped out a bunch of those triglycerides and we now put the alphabet soup in front of it, we call it a VLDL. I want you to notice the ratio of the red little rhomboids with those little strings, and then the cholesterol inside that zit. Okay? These last 2 to 6 hours after the chylomicrons have dumped, and this does not say 500, it says 50. And that's a pretty good size for a VLDL. As those dump out some more triglycerides, offering the best of the best to cells, it gets rid of some, and you'll notice here we've got about a 50-50 ratio between triglycerides and cholesterol. And this number is 35. It's smaller. It's the same particle. It's not changed. It's just a different size. So we call it an intermediate. We change the letters. But it's still a traveling zit. It's still a lipoprotein. As that IDL spends a few hours in your circulation looking for a home for those triglycerides, it also dumps them out. And as it does that, we now find our bad boy, that LDL. The LDL, bad cholesterol, causing heart attacks everywhere. And you'll notice these guys weren't like off their rocker. It does have a lot of cholesterol in there by now. But does it predict a heart attack? I would contend not when you're looking at it this way. LDL cholesterol, it does have a marker on the outside of APO B 100, so do all these other alphabet soups. It can last up to 4 days in your circulation. 4 days is actually a predictor of who in the room is going to end up with the heart attack. Who's going to turn their LDL cholesterol into the bullet version. So, NMR, if you have not had one of these, Dave Feldman's team allows you to order them with skipping the argument with your doctor. You are then going to need to know how to read it, so listen up. This is what it's going to report out for you. It's going to show you what are the size of these particles floating around your blood. It takes the blood, it puts it in a magnet, and it says, here's the size, here's the number. This is a much more advanced cholesterol panel than the one we used in 1955. And I'll show you how to find some bullets. Do you have bullets, especially if you have that data? All right, so let's go back. VLDL. VLDL was the first alphabet soup. It's right after chylomicron. It's 50. And you'll notice along the bottom, there's a green side, that's good. A red side, that's more dangerous. And on the spectrum of is this a good size VLDL, we're right in the middle there at 50. But I want to show you what happens in healthy people, and then I'll compare it to what happens in people with insulin resistance or those who are not so healthy. This VLDL starts out around 70 nanometers. And as it enters the circulation with its fancy job of delivering triglycerides, it ports all of those triglycerides into cells. This is a muscle cell, if you didn't recognize it. My kids said, nope, that doesn't look at all like a muscle cell, Mom. I'm like, it does too. The nucleuses are exactly where they're supposed to be. But those triglycerides go into muscle cells and many other cells. But as you look, it's a couple of hours before it's deposited most of it. And now that VLDL, that zit, could be done. Watch what happens next. Some of them recycle back up into the liver, and some of them become smaller. It's now a green-sized LDL, 45 nanometers. And we are on to the next chain of delivery vehicles. We've changed the name. It did not change anything else more about it. It just changed the name because it's a different size. Its job is still to deliver triglycerides, and you'll notice that it's pretty equal at this level. The triglycerides, the cholesterol, about 50-50 inside that zit. And now, the 35 nanometer size particle, well, it's going to dish out some of those particles. Some of them got recycled back up into the liver, and some of them are still hanging out, so that when your 1955 panel is done, it could measure this, or at least it could tell you this. Is it really measuring that LDL cholesterol in that 1955? So for 2 to 3 days, this could circulate, and it's going to find a home. Who needs triglycerides? Mayday, mayday, who needs triglycerides? And it's still trying to get rid of those particles. But if nobody wants any more, it recycles. It goes back into your liver, and we start all over with a new process of saying, when they eat again, we'll do this again. So as you watch the process inside your body, this is a microscopic view inside your blood vessels. The blood vessel is traveling to your liver, and the catcher's mitts that are along that liver, they're called receptors. They can recycle our traveling zits. If you look at that fuzzy thing along the bottom, well, that's called a glycocalyx. And it's going to be really important as we study the folks who aren't so healthy. If you put your finger inside your own red blood cell or inside your own blood vessel, you would feel a squishiness that is this like glycocalyx, a slime layer that prevents things from really touching those endothelial cells, those cells that line the blood vessels. And we can predict what is your glycocalyx. Is it nice, strong, and spongy, or has a swarm of moths come in and is it moth-eaten or absent? So in this case, we have a nice, lovely glycocalyx, and here come our particles into the receptor sites, and they say, yep, we are the unused particles. We don't have any other place to drop off our triglycerides. Can we go back home? The time spent from exiting the liver to entering back into the liver, we call a residence time. How long did it take up housing inside your blood vessels? As you look at particles coming behind it, you'll see the particles get swept away off into your liver, and the amount inside your blood stays low. That is healthy. So here's the lineup. If you have to take a picture, this would be a good one, where you start with those bigger VLDLs. It dishes out triglycerides until it gets somewhere near 45 nanometers. And then we change the name of it. And in the IDL, you'll notice it goes from red to green along the bottom. It's an IDL, we now deliver triglycerides until it gets smaller. But look at that LDL. The color of the arrows is green. As soon as it gets into those 20s, well, shoo fly, get back into the liver. Don't hang out in my blood. Okay, we're looking for where are those bullets? Those LDL particles that got too small and they changed. They're deadly. So here's our liver again, our muscle cell. And this is insulin. When insulin is present inside our bodies to an excessive amount, insulin sends a message. It says, hey, we got enough sugar around here, put it away, get it out of the blood system. And one of the first places your body puts it is the liver, a wonderful storage bank because it can go in and come right back out with a blink. Very easy to deliver the glucose that's stored in your liver. But if your liver gets full, it does some organizing. It says, take that glucose and make them into strings called glycogen. And these are little glycogen balls, which is about 10,000 glucose points in each one of those balls. So we can store a lot of glucose in your liver. But if it gets full of this, we now take it to the next level where it's not reversible to sugar anymore. We're going to take these strings of sugar and we're going to make them into strings of fat. This is the point of no return, folks. You cannot take a piece of fat and turn it back into sugar. The only way that fat comes out is to either burn in your mitochondria or turn it into a ketone. Now you've got fat in the liver. And when that fat liver gets its storage full, it starts to make more liver, and then it turns it into globs of fat. And now, if I was at an autopsy looking at a liver that looked like this, I would not be able to tell you if this was an alcoholic's liver, or if this was a diabetic's liver, or a pre-diabetic's liver. They look the same. The pathology is the same. It's the same process. You're storing the excess energy for that famine, that time where you don't eat, which we don't do anymore. VLDL, again, starts our journey. Chylomicrons, we're going to assume you guys all got rid of those. We are now at VLDL 50-ish points. I think this one's 80, maybe 75. But as that VLDL starts to circulate, saying, hey, I got triglycerides for sale, I got triglycerides for sale, it's quickly trying to get rid of them. But everybody's full. They all have plenty of food. It can't seem to get rid of it. And it stays there. At the end of 6 hours, it's still kind of there. You've got a few that deposited, and they did indeed reduce the size into a smaller size VLDL, where it slid down that thing. It's now not quite green. It's kind of yellow. It's not quite green. I can't say green. It's not small enough yet. It's 55 nanometers. It's going to stay there. And in the rear view mirror, you can see there's a whole bunch of VLDLs just like it. It's circulating. It's not going anywhere. It can't recycle. Now you've got some IDLs, and once again, it's going to give out an APO B. Anybody need triglycerides, like the ice cream truck, except it's not ice cream. Nobody's taken their triglycerides. They're circulating. Those zits are accumulating. And God forbid it's time to eat when you haven't done all this yet. We're now 4 days into this little turkey floating around, and your LDL, it's now purple. And the size is, it's in the red zone, folks. It's been around too long. Well, I don't want that. How do I know if I have that? There's the question. When you look at your bullets of whether or not these are the ones who cause the death, let's start by saying, here's your liver. And that liver is filled with the sugars, who are filled with the glycogen, who are filled with the triglycerides, and filled with fat. So those catcher's mitts, well, they fell away. They said, what do you need me for? My job is to take these receptors, take these balls of zits and put them back in the liver, but we're so stinking full, I need to make some more liver cells before I do that. So the number of catcher's mitts when the liver's full is very low. And now you'll notice a whole bunch of LDLs coming along. The residency time is long for these folks. They've been around. They've been circulating. And they've got a crop right behind them, but only one of them is recycling that back into the liver. It's very slow. We've got a lot in there. Now we're going to add to the fact that this setting happened because of high insulin. And that insulin was known for doing some things that are opposite of a good idea. That little Glycocalyx is gone. It now no longer protects you from, well, this lecture that Dave Feldman just gave, which is, how do we get what happens when those LDL particles are massive in our circulation, and now they can touch my endothelial cell readily? Well, we're going to describe it like this. The endothelial cell changes, and we're going to slip them right through the wall. It's not quite how it happens. Listen to Dave's lecture for that part. And then the immune system does what it should do. It says, hey, you do not belong here. Get the heck out of here. We know better than for you guys to be in the cell, in the wall of the artery. And that swarm of white are your white blood cells saying, hey, go away. You do not belong here. And if there's only a few dozen of those particles, no problem, your body will win. But if there's millions for the last 15 years, well, that's how you form a zit. Whether or not your zit is ripe or not is the next question. So let me recap. Here was the healthy cholesterol. Here was the healthy liver. It is beautiful. It does not have an excessive abundance of sugar or triglycerides or fat in it. The VLDL turned into IDL, some of them recycled. The IDLs turned into LDLs, and some of those recycled. And they tucked back into the liver when the body didn't need them. Very efficient process. When I do the blood test of somebody who is in this state, the triglycerides that I'm doing in your liver panel come from taking those little balls of fat in your circulation and pulverizing them and saying how many triglycerides were in there. And yes, triglycerides are going to come from those LDL, but it's been recycled. There's not a lot of them. Let's say you've got one straggler of an IDL around and one straggler of a VLDL around, so you have a few more triglycerides that are going to be in my blood test. What does that look like in a reality? Like, what are the numbers? This patient would have an APO B, meaning the number of particles that are in circulation are 40. That's beautiful. Anything under 90, good idea. Triglycerides, well, these are 65. Ever heard your doctor say if your triglycerides are lower than your HDL, you're going to live forever? Yeah, well, there's a little truth in that it's a really good number. It is behind a whole complex math equation that says, well, I'm guessing that I understand the other parts of that equation. That cholesterol-laden liver, that fatty liver, that high insulin. Folks like me who'd been overweight for over 10 years before I hit the ketogenic diet, and then said, wow, my liver enzymes aren't abnormal, but I like them below 25, and they're not. There's something up with my liver. And what was up with my liver is I was storing a whole bunch of energy in there that I couldn't use. That if you look at pulverizing these cells, it's going to pull the triglycerides over and put them in a pile. It's going to pull the total cholesterol over, put it in a pile. But if I look at how much of the triglycerides are coming from the VLDLs and the IDLs, this triglyceride is 250, which still ain't bad for some people. When it gets into the 800s, the thousands, there's a reason it's linked to things like pancreatitis. Your whole body is panicking, trying to say, how do I get rid of all this fat? So when you look at total cholesterol, you might hear a physician say, well, I study non-HDL cholesterol. Okay, that's a little better. Still, like, we made it from 1955 to 1970, maybe. Where the total cholesterol is those yellow particles that are inside the traveling lipoproteins, that it will take the HDL and subtract it. It's going to do some math with the triglycerides. That LDL cholesterol on your panel is calculated. It is not measured. But the calculation comes from broken math. They took a bunch of these particles, they pulverized them, and they said, yep, here's the triglycerides. Here's the total cholesterol. Now let's do some funky math, and we will predict heart attacks from it. And the process is flawed. The process needs to be a ratio of how long have your particles been in your blood, what size are they, how quickly can you recycle them. That since 1965, there has been a test called APO B, most of which us never heard a thing about in medical school. It's cheap, a few bucks. Dave Feldman's team does this too. It is a wonderful way, if I'm going to study somebody and look several times over a year, I like to look once a month when we get to this phase. What's your APO B? What's your APO B? What's your APO B? Not looking every 6 months. You can't stay motivated that long. I'm saying humans can't stay motivated to switch a lab number that's related to the nuance of how you eat when they only check it a couple of times a year. Your NMR, which is telling you which particle sizes you have, great idea. More expensive and kind of an arm wrestle between you and your doctor. APO B should not be an arm wrestle. So looking at how I help patients prevent heart attacks, it starts with don't smoke, period. Check your blood pressure. It does need to be normal. But the third test that I check is actually hemoglobin A1C. What is your average blood sugar? Again, trying to find a way for medicine to go directly to you. You care way more about your body than your doctor does. I care about my patients, but I can't possibly care as much as you should. Checking your A1C every month until it gets down to, I like mine below 5. I'm not there right now. The second thing is C-reactive protein. How inflamed is your blood vessels? How much inflammation is your immune system having to live with, your brain, your heart? How squishy is the glycocalyx inside your blood vessels? Then, and only then, do we start to say, now, how many particles of fat are you carrying around at any one moment? And this is where we take your ketogenic diet, your version of low carb, of carnivore, and we say, all right, how far are you along a continuum? And if you look great, fantastic, keep what you're doing. But the numbers are important to predict who's going to have the next heart attack. Looking at APO B and getting it under control, very big idea. Very important in the long-term journey of the area under the curve. Because this APO B hasn't been high for a few weeks. It's been high since you first started gaining weight. And now, how much of that is being stored in the walls of your coronary artery? Well, it has a lot to do with area under the curve for the number of particles in your circulation. So, I do not think that the ketogenic diet has one size fits all. I think many people are on an easier path where they can reverse the problems without doing some of the things that I've had to do, or my patients with cancer or seizures or advanced metabolic problems have to do. I do believe that you're not on the ketogenic diet if you're not making ketones, that you are reversing metabolic problems, that you're decreasing the inflammation in your system, and you're finding a way for those cells to do the best version of autophagy, turning over and giving them a fresh, new blueprint for your body today. I teach this in my clinic, but I also wrote a book, Keto Continuum. It is the steps that you do not need to see me to do these steps. The workbook, I make every one of my patients do. They have to fill it out. They have to own the journey more than I do. And that begins with documenting the steps and doing this in a way that says, how well can you predict your heart attack? It is about these risk factors. And although cholesterol becomes this divisive place in the ketogenic space, there is very good evidence that you shouldn't be overweight. You should have normal blood pressure. You should not smoke cigarettes. You should have an A1C that's around 5. You should have a C-reactive protein that's low. And that your APO B does need to be part of this equation. I'm going to finish ahead of time.